Good morning. I'm Carolyn Meltzer. I am the Dean of the Keck School of Medicine. It is an absolute pleasure to be here with you today. And I have the honor of welcoming you to this special event, which, while part of the grand rounds in the Department of Population and Public Health Sciences, is a special version of our grand rounds. As you know, at the Keck School of Medicine, we are deeply engaged in the health of our communities, and that partnership with the LA County Department of Public Health has been a strong one. So we're really honored to welcome back Dr. Barbara Ferrer, who is director of the LA County Department of Public Health. And she's been leading the efforts to manage and overcome the COVID pandemic in our county. For the past year and a half, I don't have to tell any of you how much COVID has been a disruptor for the health of our communities and our medical system as well. And partnering with the LA County has been just critical to conducting research in the community, to providing access to resources. And this incredible collaboration continues to yield information about the attitudes, behaviors, immunological responses to the pandemic across the LA County residents. One of the things that absolutely drew me to USC was the engagement in what is one of the largest, most diverse cities in the country, and that partnership is critical. So I'm going to now introduce someone who needs no introduction to this group, Dr. Howard Hugh. He is the Flora L. Thornton Chair of our Department of Population and Public Health Sciences. Dr. Hugh will formally introduce Dr. Ferrer and our event panelists and moderate the discussion to follow. So please join me in welcoming Dr. Hugh.
Thank you, Carolyn. We're so happy that you arrived here from Emory to warm climes to enjoy USC and also to lead us as we forge ahead. Barbara Ferrer, we're particularly delighted to welcome you back. You've been here before to tell us what was going on in LA County near the start of the middle of the pandemic. And we are so fortunate, all of us living in this county, that you're directing the LA County Department of Public Health, because you not only oversee what the response has been to the pandemic, but you also work on all the other aspects, what the county is engaged in protecting health, preventing disease, promoting equity and well-being among the 10 million residents of our county. And in the course of doing so, managing a $1.3 billion budget, directing a workforce of about 5,000 staff, and integrating services throughout, and also in conjunction with the Departments of Health Services and Mental Health. I had the great privilege of knowing Barbara in Boston when we were there. She was the director of the Maternal and Health Division in the Massachusetts Department of Public Health while I was at the Harvard School of Public Health. But she's had so much experience as a nationally known leader, as an educational leader. She has a master's in education, and in addition to her PhD and a master's in public health and being a member of our tribe, a philanthropic strategist, a researcher, community advocate, and a public health director, of course. She also oversees the major collaboration we have with the county on the LA cohort pandemic surveillance study, which we are doing in collaboration with Paul Simon, Will Nicholas, and colleagues. Such an important vehicle for understanding behaviors as well as the antibody response to the COVID epidemic. And these kinds of collaborations align with the aim of our department to forge a stronger and stronger partnership with the county as part of our vision to be a leader in urban population and public health sciences, but engage deeply in Los Angeles in moving the needle on public health. We also have as panelists today, Frank Gilliland, known to all of us as a leader in environmental health and a professor and also the director of our pandemic cohort research center. David Conti, who runs the statistics working group of the Pandemic Research Center and is also, of course, a well-known professor of biostatistics. And Michele Kipke, who's not only the co-director of our university's Clinical Translational Science Institute, but also as a behavioral research leader. She's been instrumental in co-leading the Vaccinate LA campaign, which is such a thing of pride for us to be, again, deeply engaged in the community and moving the needle on vaccination rates in one of the poorest and highest minority communities in Los Angeles. So without further ado, Dr. Ferrer, I will turn the floor over to you to share your insights. Dr. Ferrer will give her presentation, followed by the panelists who will be invited to give about 2 or 3 minutes of comments and to ask a question to Dr. Ferrer, and then we'll open up for discussion. We will have a microphone that's over there and over there for our those of us who are in residence to line up and ask their questions. Dr. Ferrer, please welcome Dr. Ferrer.
Thanks so much. It's really a deep honor to be here. I want to particularly thank Dr. Hugh for inviting me. I want to welcome our new dean. We're so excited to have you here. I want to thank all of you and everyone who's listening remotely, just for the work you've been doing. There's not a single person in this room who hasn't both had to live through some of the most difficult times any of us have ever had to live through, but who hasn't also contributed to the response. I'm particularly grateful. Both Rashmi and Paul are here from our team at the Public Health Commission. I know, lots of people, have seen me, but, I'm not alone in anything I do. I have an amazing team at the Department of Public Health. I also have an amazing team in this community, so many great partners, academic partners, business partners, residents, community-based organizations, faith-based organizations. And that's been, I think, what's gotten us off there. Our ability to take care of each other is really a testament to these partnerships, these friendships, these relationships, and the ability to sort of dig into a really, really difficult work. So, honored to be here. I have a lot of slides, so I'm going to go fairly quickly through some of them. I'm anxious to, both hear from our esteemed panelists. I want to thank all of them for being here with us as well. And I want to hear from, folks here and, try to make sure we're engaging with you and hearing from you, your ideas as well. So I'm going to try to cover, really 4 big things. What's been the course of the pandemic in LA County? I want to talk a fair amount about the disproportionate impact of this pandemic. I want to talk a little bit about post-surge plans. We call ourselves post-surge now, and then close with some suggestions for where we need to go and what we need to do together. So, those of you who follow the pandemic, this is a slide we show every single week, and we post it and share it on our dashboards. And it really captures the trend line for this pandemic, looking at cases, which is that green line, hospital admissions, which is the yellow-orange line, and deaths, which is that blue line. And you can all see pretty clearly on here, that we've had 4 what we call waves of this pandemic. 3 of them, the 3 last waves, driven by variants, Epsilon, Delta, and now, coming out of Omicron. I want to note there's always, as you can see here, a relationship between cases, hospitalizations, and deaths. Cases start going up first, then hospitalizations lag a couple of weeks behind that, and then deaths generally lag even more. There's also always a relationship between cases and hospitalizations. I say that because for everybody who's out there saying we don't have to worry about cases, I'm not sure how you get away without worrying about cases, because cases drive hospitalizations. And hospitalizations generally are a predictor of sadly, the people who are going to pass away. We do know that the relationship between cases and deaths changes, cases, hospitalizations, and deaths changes over time. You could see a little bit of this most clearly with what happened in Omicron. So, if you look, you'll see for that winter surge 2021, there were about 5.5% of people who ended up being positive ended up requiring a hospitalization. Slightly less when we got to the Delta surge, that was the last summer, where it was about 5.4%, and much less when we hit Omicron, 1.7%. Was sort of the, these are just crude ways of thinking about this relationship, but always a relationship, and always that relationship tempered by what tools we have available. So, we think about what's going on with Omicron. We have vaccinations, we have boosters, we have access to good testing. Same in, sort of started seeing some of that during Delta. Also have a whole bunch of people with some natural immunity, both from Delta and now from Omicron within these last two waves, which, came, as you could see, as our waves do. Summer wave, winter wave, summer wave, winter wave. I've talked a little bit about cases just to note that the messiness of the time we're in is that for different reasons, we're not going to know all the positive cases, but we've never known all the positive cases. Not from the very beginning when we couldn't test anybody, not to the point where different people had different access to testing, and not to the point where we're at now, where people can test themselves in the privacy of their home, and that information is not reportable. So testing and the relationship between those positive results and what we know about who in fact is infected has always been an underestimate. What we're reporting always an underestimate, the magnitude of which we really can just estimate from some of the studies. Dr. Simon, who's here, estimates that for every case that we identify, there's probably 3 to 4 cases we don't identify, and that we should just, note when we consider, sort of what's happening in our community. So always, what we're reporting out on positivity is really an underestimate. We've used a variety of mitigation strategies throughout the pandemic. We've always relied on non-pharmaceutical interventions. Thank you all for keeping your masks on. We think this is a pretty effective one. And I think for those of us who remember back to the very beginning, when we didn't know that people should be wearing masks, we just thought, we just had to worry about people with symptoms. We didn't, we kept getting told, epidemics not driven by asymptomatic people. That's not true. So the masks were super important at the beginning, and now they're important for a different reason, because the vaccines don't necessarily provide as much protection as we would like them to be providing in terms of transmission. So these masks have been super important. Ventilation has become more and more important as we recognize that the virus can be transmitted through airborne particles. Something, again, we really remember we scrubbed every surface that we touched, because that was the big worry. Wasn't really thought to be airborne at all, but now we found out some different things. And we've used health officer orders, and in some cases you've seen executive orders to actually drive requirements, to note some recommendations. And we moved back and forth between those requirements and recommendations, depending on what was going on. We've also used testing, vaccinations, and now therapeutics as major mitigation strategies. And I'm going to talk a little bit about our investments in provider networks and creating easy access. And then there's been the important work around care and support. So those of you who are here, who are part of your hospital care system, your clinics, bless you, thank you. We owe you a debt of gratitude for everything you've been doing. And that's a massive system of care. There's also the contact tracing care, quarantine and isolation sites where people can go who are either unhoused or can't really appropriately quarantine or isolate in their homes, and a lot of information sharing. I want to just put this in context, give you a few numbers just to understand how much work this really involved over time. The health officer, Dr. Davis, has issued 119 broad health officer orders over the course of this pandemic, 119. We've also issued a total of over 1.2 million isolation orders and another 206,000 quarantine orders. We've interviewed almost 800,000 individuals as part of case interviews and another 260,000 close contacts, full interviews. We've had about 650 or more community health workers, promotoras, throughout our communities, really connecting people to care, connecting people to services, giving people good information. We have contracts and funding going to, I think, almost 60 community-based and faith-based organizations that help us again with information sharing and getting people to and from vaccination and testing. We've conducted over 600 telebriefings over the course of the pandemic, where we've reached over 150,000 participants. These are very sector specific. We work with the business sector, we work with grocery stores, we work with labor unions, we work with, we hold town halls for residents, pretty much every sector, schools, institutes of higher education. We've been running weekly telebriefings for just about every sector. And we have a lot of information that goes out on social media. I think we have about 350,000 followers on our social media platforms. You can see here that we try to sort of track some of the big changes we make around health officer orders, requirements, and recommendations with what's happening over time. I don't have time to go through this, but you can see pretty quickly that there have been times where cases have started to rise, and that was safer at home, stay at home, that was masking requirements, and then as cases dropped down, some of those health protection measures have been rescinded. And this has happened throughout the course of this pandemic. We've also, really had to build up, and this, I don't know, how much people appreciate how challenging this part has been, build up these massive systems to ensure that folks had access to what we consider some of the most powerful mitigation strategies that we have: testing, vaccinations, boosters, and now therapeutics. And you can see how challenging this was. This is a map in May of 2020, where, we all knew testing was super important, but we actually, it took us from January till May to get 93 sites across this huge county, 4,000 miles. And you can see, looking at here, you go up north, we had hardly any testing sites. Go into places like South Central, go out to some of the valley areas, we didn't have enough sites. Doing much better, I want to say again, a testament to the ability to sort of stand up to these challenges. We have about 330 total sites in the network that's managed by the county. So there are other pop-up sites that actually we don't know about, and we actually don't include because we don't have enough information about what they're doing. But these are the ones that we actually as a county know about, know that they're reputable, know that they offer free testing, which is super, super important to be considered as part of our network. We learned a lot about not having good testing access at the beginning. So from the very start of our ability to vaccinate, by the time we got to May, when we were actually out of scarcity and were able to vaccinate most people, we already had over 850 sites across the county. And then, you look now, we have over 2,000 sites, a lot of fixed sites, and then we have our mobile teams that are out every week. We average somewhere between 600 and 800 mobile teams that are, sort of we manage through the county, out and about, popping up wherever we can. Labor unions can ask us, a business owner can ask us, you guys can ask us, churches, mammoth effort. We're at schools, we're anywhere people want us, particularly at this point. And I want to note that the reason why there's been such a heavy emphasis on our vaccines is the vaccines are really effective. And this is if you look at our case rate data. Now I'm going to look at the recent time frame only. I'm not going to extend all the way out. Even though we all know there's waning protections from vaccines, I want to note as you look towards the rate ratios that we have, towards the end of this tail here, they look like, things are pretty close together. We have seen some changes over this last year in the relationship between what's going on for people who are unvaccinated, what's going on compared to people who are vaccinated, fully vaccinated, and then compared to people who are vaxxed and boosted. But you can see at the height of sort of Omicron, unvaccinated people were 2 to 4 times more likely than vaxxed people and vaxxed and boosted people to get infected. And that ratio has pretty much remained the same. So if you're unvaxxed, you still are 2 times more likely than vaxxed people to be getting infected. There was a time, if we were to go back and look at this, when these rate ratios were much bigger. That difference was 5-fold, 6-fold. At one point, I think it was almost 10-fold. And I'm going to talk for a second about some of the reasons why we see this. But I want to note the biggest change has been in what's happening between vaccinated people and vaccinated and boosted people. Where actually, it doesn't look like there's much of a difference at all. And certainly for cases here, that could be pretty concerning because it looks like if you were boosted, you actually are more likely than just those fully vaxxed to have a lot of protection. Some of the things that we think account for this is obviously we all know there's waning protection from boosters as well. Most people got boosted 6 months ago. We also think in that unvaccinated group, you got a lot of folks who actually have some natural immunity. And that natural immunity, just like everything else, it boosts the response and gives them some protection, and it's not captured here. During Omicron, we know the numbers. So over half of the people who got infected were vaccinated, but the other half were unvaccinated. And they've got some natural immunity that needs to be taken into account. It's pretty hard to measure that. We also know that, because early on, and you can look at the data during the height of the Omicron period, boosted people actually had a lot more protection and were less likely to get infected than those who were fully vaccinated. That means that we got a lot of fully vaccinated people who also got a boost when they got infected with Omicron. Super hard to capture that in these rate ratios. So the rate ratios are helpful because it lets us understand what's going on in real time without a study, but they're limited because we can't really tease out all of the other factors that might narrow or widen those rate ratios. And the same thing, you're going to see this, I'm going to look at it for hospitalizations. The good news is the gaps, the rate ratios here stay pretty large. So really, here's where we know how powerful these vaccines are. Again, if you look at what was going on with unvaccinated people compared to fully vaccinated and boosted in the height of Omicron, unvaccinated people 21 times more likely to get infected. And even now, with all of sort of that confounding that I talked about, there's still a pretty big difference here. And the same thing holds on deaths. And the interesting thing is with deaths, the difference is, again, remains pretty wide. So the protection against severe illness and deaths is still really important for us to emphasize, because sometimes you look at all of this and you're like, why bother getting vaccinated? I'd say there are 2 reasons. One is you're kind of playing a little bit of Russian roulette if you decide that the way to get your immunity is to get infected. Because a lot of people die still. 32,000 people have died in LA County. A lot of people continue to have long COVID. Lots of people end up being hospitalized, and you're not really sure when you decide, that my strategy is going to be to get infected to get this protection, what your outcome is going to be. So pretty risky to go ahead and say, I'm just going to get myself infected and get that natural immunity, because you could have a pretty bad outcome. And as we can see very clearly, the vaccines protect you from the worst outcomes. So we try to encourage people to actually look at this data and understand how powerful a protection these vaccines continue to offer us, and how lucky we are that, 3 big variants out, the vaccines are still providing this level of coverage, because that's 3 very big mutations from when the vaccines were developed. And I want to just note, the challenge right now is to build out a network for therapeutics, but already we've got over 400 sites distributing therapeutics. And because we know that people are having a hard time getting access, particularly to the oral medications that are now available within a good time, you have to get them within 5 days of developing your symptoms. We have a test to treat telehealth service. So people who have I test at home, I'm positive, you can call us. If you don't have access to a provider, your provider can't help you quickly. You can call us, we set up a telehealth visit that day. If in fact, with the clinical provider, you are a good candidate for the medication, we send it to your home overnight. And that's for the entire county. So again, understanding how important it is to make sure that everybody has access to this. We're not waiting till we can build out what we need, which is 1,000 providers to be able to do this and distribute this. We're actually created this alternative model. But in spite of all of our very best efforts around trying to have strong rules and recommendations about how we can protect each other, couple that with good access to testing and vaccinations, boosters, and as you've seen now, therapeutics, we've got a pretty devastating picture that we've witnessed throughout this pandemic in terms of disproportionality. So you could see here that from the very beginning of the pandemic, we've been haunted by these inequitable outcomes. So, this is starting to look at our case rates. And I just want to note that sort of from the very beginning, the Latinx community was hit particularly hard. And if you look at this, you can see that, at each of these peaks, the story's a little bit different. I want to note that during our Delta peak, for the first time, the Black community ended up having higher infection rates than the Latinx community. But pretty much consistently, Black and Brown communities in LA County have had the highest case rates. And if at the very beginning, when we first started, Latinx residents 4 times more likely to get infected than anybody else. In this last round, they're about 1.5 times more likely to get infected than white residents, which was, again, as you can see here, they again, hardest hit. You see, of course, the relationship between cases and hospitalizations holds up. And as you could see, what we've had is like huge differences in hospitalizations. During the Omicron surge, 3 to 4 times higher rates of hospitalizations for the Black and Latinx community than for our Asian and white community. Pretty dramatic differences. And this followed with deaths as well. 2 to 3 times higher during Omicron for Black and Latinx residents, and pretty big differences that I capture here in terms of cumulative age-adjusted case hospitalization and death rates. Consistently, as you could see, these are stark. You can see these very, very big differences between what's going on amongst our Asian residents and our white residents when compared to Black and Latinx residents. I think in part, this really reflects exposures, sort of who's getting the most exposures, community conditions, and health status. Where people live and work really matters, and we've known this for a long time. Essential workers never stayed home. At the beginning, we failed to know enough to provide protections to those essential workers. Then we struggled with enforcement of protections and allocation of appropriate resources, particularly around testing and PPE. Folks who are getting infected at work, oftentimes many of our essential workers in particular, low-wage workers, non-unionized workers, workers in places where there were lots and lots of exposures. We've gone into factories where the conditions were absolutely atrocious. They then return to densely populated communities and overcrowded housing. There's no pay for many of these workers when they're sick, and that's especially true even now for folks who are in low-wage, non-unionized jobs with sort of either day work or they work in small settings under 25 workers. They're here without their papers, so again, lots of reasons why we see this, but we have to acknowledge what this reality has meant. And similarly, we see differences by geographic regions. Often, because there's so much segregated housing, this actually pattern really closely mirrors what we might see when we look at communities that are highly populated by Black and brown residents. This is the first year of the pandemic. So I put this up. You could see the lighter shade areas have much lower case rates. The darker shared areas, for those of you who aren't familiar with LA, South Central, San Gabriel Valley, East LA, parts of San Fernando Valley, and starting to see some things happening up north as well. Santa Clarita, and then obviously in Antelope Valley. The thing is, it didn't change much. So this is the cumulative map. Those same wealthy communities still had, lower case rates. The only big difference you actually see is what was going on up in Antelope Valley, where in fact, you started seeing more dense, or you start seeing higher case rates in those communities. And similarly, obviously, we have big differences in where people died over the course of this pandemic. If you actually, look deeper into these communities, you can see that there's also a huge gradient that we can look at that really is related to how much poverty there is in a community. So we use area poverty here because it's super hard to get individual data on this, but I think it's a really decent proxy. And I want to note that the people in the wealthiest communities, less than 10% of the people in those communities were living under the federal poverty threshold. You could see they have lower case rates and significantly lower death rates when compared to people living in communities where there's a lot more poverty. If you actually look at this for hospitalizations, sadly, you see a gradient both by race here. And this is recently, just looking at not cumulative now, but what's going on right now. And the reason I put this up is I think it's important to understand that vaccinations are not the equalizer. Like everyone, people look at these slides we put up and they say, that's a proxy for who got vaccinated, who didn't. More people got vaccinated in rich communities. That's why, everything looks better in those communities. It's actually not true. And it's not true because even people fully vaccinated, if they're people of color like they are here, you can see that they still had higher rates of hospitalization when compared to other people who were Asian and white who were fully vaccinated. And the same thing holds, like Latinx people who are unvaccinated, much more likely to be getting infected than others. Starkest differences we found when we looked at this by area of poverty. So you could see here the gradient, as communities have more, are experiencing more and more people living in poverty, they obviously are having higher rates of hospitalizations. And this is huge difference for unvaccinated people. If you're wealthy and you're unvaccinated, your hospitalization rate is 13 per 100,000. If you're poor and you're unvaccinated, it's 157 people per 100,000. And if you're fully vaccinated and you live in a community with high poverty, your rate of hospitalization is the same as the rate of hospitalization for rich people or people living in wealthier communities who are not vaccinated at all. So vaccinations are great and they're super important, but they're not an equalizer. Same thing you could see here with deaths. There's so much higher death rates for people living in communities where there was a lot of poverty. And not surprising, we also see this if we look at our mortality rates. So, obviously the most striking, piece of information from these trend lines is how much of an increase we've actually seen in all-cause mortality for the 2 years that we've really been living with the pandemic. We're not necessarily sure of all of the drivers, particularly of non-COVID deaths, but we're going to go into that in a second. But you can see here that there's been big increases. The top line is, all-cause mortality always has been highest for Black residents. It went up significantly during the pandemic, as did everybody else's. In 2021, everybody except for Latinx, the Latinx community saw a small drop. If you look at the percent increases, huge differences, 48% increase between the pre-pandemic, between 2019 and 2021 for Latinx, and then it drops off significantly down to 7% increase in all-cause mortality. And we actually can look at the 2020 data and compare it to 2019 and look at what percent of these excess deaths are attributable to COVID. And you can see, again, huge differences here. 80% of what you saw in that smaller increase amongst white people is attributed to COVID. For Black people, it's slightly less than 50%. And this also shouldn't be so shocking to us. If we look at our death rates in 2020, you can see what you saw on the trend line. Black residents, almost on every mortality indicator we are tracking, had the higher death rates. The only place that didn't happen was among COVID-19 death rates. And in that place, the Latinx community had the highest death rate, mortality rate. And I also showed that the second highest rate of mortality is often experienced in the Latino community. Particularly interesting to note the very high death rate, mortality rate for Latinx community for diabetes, given all of the new research on the connections between diabetes and COVID and sadly, poor outcomes. I'm going to go really quickly through this next group, but I just want to note, again, not to, have everyone jumping to a conclusion that this disproportionality, as sometimes when we looked at the COVID disproportionality, is really related to individual behaviors. And because the evidence is sort of super conclusive that would be a wrong conclusion. And we're not going to have time to sort of look at everything. But I just want to show you, and you'll remember the maps about where people were hit the hardest for COVID. These are also what we call the HPI communities. We've overlaid, these are communities that are disadvantaged with less health affirming resources than other communities. They're looked at, there's 11 different community characteristics here around the economics, housing, environment, social connectivity, education, transportation. And then we overlaid that as well with those communities that had very, lower vaccination coverage rates. And you can just see, like, again, similar communities to where you just saw devastating impacts from COVID, but also these are communities that have large populations of Black and brown individuals. The same thing, this is the pollution burden in LA County. There's pollution everywhere, but there's a lot more pollution in some of these hardest hit communities. And the same thing where our food deserts are. Again, we have some communities where much easier access to healthy and affordable foods than others. And again, really kind of mirrors what we saw where we had pretty bad outcomes in terms of COVID. So it does leave us to sort of, what does that mean for us now as we move forward? The first thing I want to note is, and this might be a little controversial, is we still think as a public health department, we have an obligation to reduce serious illness and deaths from SARS-CoV-2. It's not, we don't think it's appropriate to sort of tolerate this disproportionality that's resulted in these higher rates of illness, death, long-term disability among some of our residents and workers. And the reason we don't think we should be tolerating this is we know there are collective preventive measures that we could be taking that would mitigate. So I know there are a lot of people at this point that are tired of the pandemic, want to create a new normal, and in that new normal, they want to rest on people just taking individual responsibility for what actions they're going to take to mitigate against the threats of the pandemic. But when I talk about collective prevention measures, I'm saying that those are public health measures that need to continue to be taken. And that we are nowhere near saying that the severity of illness that we're seeing and the deaths that we're seeing, particularly because they have a disproportionate impact on some of our communities, is tolerable. And we can just move forward, tolerating what's going on right now. So we're not there. We think there are vulnerable residents that still need to be protected. This includes people who are older, people with underlying health conditions. Those are what we all know about and talk about a lot. We also think this includes, as I've just shown you, is people who live in communities with high poverty rates, Black and brown residents, those people that are unvaccinated, not fully vaccinated, and those people that have a lot of exposures at work and in the community. And we as a public health department want to continue to, in this post-surge phase, make sure that we're acknowledging our collective obligation to protect those most vulnerable. So we're not buying into sort of, it's like do as you want at this point. And that, that's a fine strategy. People can make their individual choices. So we're gonna go ahead and move into post-surge a little differently. You all know the CDC created these new community levels. I want to note this is a measure of strain on the healthcare system, not a measure of community risk. So we're going with this. We post it. You can look at these metrics. We're in low. We'll probably remain in low for a very long time, at least until we had another significant surge. And I think there are reasons why it looks good if the country is mostly in low. But it's not going to necessarily help us to take actions when that community level starts moving to moderate or high, because by that point, we'll already have seen a lot of transmission. So we do have an early alert set of signals for LA County that we monitor. We post this every week on our website on Thursdays with updates. We have thresholds. And we've actually added a new measure. So on here, you'll see 3 community-wide measures. We look at variants of concern. We look at emergency department encounters for COVID. And we look at the 7-day cumulative crude case rates in our lowest income areas. And if any of those, sort of move into moderate or high concern, we go ahead and we do investigations, we do a review, and we may propose additional mitigation measures. And then the other 4 measures that are up here are measures in specific sectors. So we're looking at outbreaks in skilled nursing facilities, our TK through grade 12 classrooms, our persons experiencing homelessness settings, that's mostly shelters and interim housing. And we also look at what's happening at our work sites. And you can see we set these thresholds based on our experiences over 2 years as to when we know that we should be concerned about what we're seeing, because it usually means that we're moving into having higher rates of transmission. Right now, there's only 2 indicators of concern. Obviously, BA2 circulating much more widely. It's a subvariant of concern, so we track it separately. And we're started to see a lot of outbreaks at our schools as soon as we took those masks off. We also have a preparedness dashboard, acknowledging that throughout this pandemic, it's our job to make sure, especially now that we know a lot more, that we're prepared for whatever's in the future. Very uncertain, lots of unpredictability, particularly with a variant, particularly with a virus that mutates so easily. But we do have a set here of 13 indicators that we watch. We're really looking at 5 different areas of preparedness: therapeutics, vaccinations, testing, outbreak management, and surveillance activities. And again, this is all available on our website, and feel free to take a look at it. We're doing fairly well on all of these measures, but obviously wherever we're just adequate, we need to continue to work to make sure that we're doing the best job we can at being prepared. I want to, sort of close with just, where does this leave us? Because one thing to have early alert systems, it's one thing to respond, it's one thing to be tracking what's going on, particularly in communities that have been hardest hit. It's a great thing for us to be as prepared as possible with mitigation strategies. But I do think there are some things we should do differently moving forward. We need to, you've seen the federal government, we're not paying for testing, we're not going to be able to pay for therapeutics, we're not maybe going to be able to even pay for vaccinations. Really, really bad strategy. Like, a lot of what we do right now rests on making sure that access to all of that is super easy, including PPE. It should be free, it should be everywhere, you shouldn't be struggling. This is a good investment. This is the investment that keeps the economy going. So hard to imagine while we're still in a pandemic wanting to actually claim that we're at the end, so you don't have to make investments in things that not only save people's lives, but keep us open. We also need to recognize that we have benefited greatly because we, as government, I think also we as healthcare providers, not necessarily always seen as trusted emissaries of information or services. So we have benefited enormously from this vast network of community organizations, faith-based organizations that are trusted, and they need money. They're the infrastructure for a pandemic response. So I want to be clear about that. Like, they are the infrastructure for the pandemic response. We don't fund them. Like, we're piecemealing grants together. Like, there needs to be steady, secure funding and an acknowledgement about how essential the work is. They're also economic drivers in their community. They give people jobs, good jobs, and they do good work. We also need to recognize that this pandemic has really highlighted how little protection some workers have. So I don't want to really spend a lot of time criticizing other agencies and departments, but here in LA County, Cal OSHA may have good regulations on the books, but it can take them 6 months to get an inspector to a factory when there's been a notation that there's a violation. That didn't work for our workers. It didn't work at all. Father John's took them 3 months to get there. So we got to strengthen this. We've used health officer orders to try to get around the sort of lack of, what I'd say strong worker protections. But even right now, we have to continue to sort of figure out, in the absence of having a strong national or strong state response, how are we going to protect our workers? We have worker councils that right now I think are a helpful effort on that. We do need to continue to look at vaccination mandates. There are places where vaccination mandates we think make a lot of sense. We know that they can be controversial, but we've had vaccine mandates at places like schools forever. So we should be judicious about how we think about this. But in those high-risk settings and where people are working with a lot of vulnerable residents, it makes sense to us to continue to look at vaccination mandates and to actually make that requirement reflective of the need for people to be up to date on those vaccines. And we also have learned that you should couple the COVID services with other services that people need, that people's lives are stressful, and oftentimes they need information and access around housing insecurity, food insecurity. We're starting to try to build that out in a couple of sites, but I think this is super important. I want to also note that, the health system was really challenged by our surges. So we got to fix this, and we got to fix the staffing issues. Like, we can't keep not having capacity within our healthcare system. We also need our healthcare providers to feel more comfortable, better supported, have the resources, so that some of the things that are being done in more public settings can move back into the healthcare system. Testing, vaccinations, therapeutics. We have these cumbersome processes right now that make it really hard for our healthcare providers to actually do some of this work, and we should be fixing that. I'd also recommend that we missed an opportunity on coordination with some of you, with healthcare services folks, and we should create some kind of council that meets regularly so that we're benefiting from shared knowledge. And it's not based on just, I have a relationship with Dr. Hugh, so like we can talk. Like, we should have a system in place where we're regularly sharing information and try to come to some consensus on preparedness and mitigation activities. And last, I'm gonna just note, we have to do some things differently if we're gonna close the gaps. It's not enough to just do what we've been doing and what I'm suggesting we need to shift. There are some gaps that are there. They've been there for a long time. These are some pretty straightforward actions that can be taken. I think we need to think about public health differently. I think we need neighborhood teams. I think we need additional resources in vulnerable communities just for healthcare services. I think we have to, again, take a look at health and medical training programs. We need to make sure we get more people of color in the pipeline for this, and that we're partnering with others on the fundamental changes that are needed to address sort of racism, discrimination, marginalization that we see play out in real time now with this pandemic. Thank you.
Fantastic. And let me first invite the panelists to come sit on the panel. While I'm doing that, I just want to say how amazingly aligned we feel with LA County's priorities as Barbara described them. And our mission, of course, is discovery and education. But there's so much we can do to uncover those strategies that will keep our population healthy and mitigate disparities. I also wanted to share with you that, you may not know it, but we have over 250 people who have logged in for this webinar. This is going far and wide. We've invited the press. I think KMBC has been logging into this. And we also have simultaneous Spanish translation for those who are logging on and only speak Spanish. So we're very proud to have tried to go all out to make this event as accessible as possible. So with that, let me turn to our panelists and let's engage, starting off with Frank and going down the line. Frank, David, and Michele.
Well, that was a really great talk. Really was a great overview of the whole pandemic. But throughout the pandemic, public health policies and interventions have really been made in the face of scientific uncertainty. And as the scientific understanding of the virus and the pandemic evolved, policies and interventions changed, leaving many people, even highly health literate people, confused about what to do and left the impression with many that public health community didn't know what they were doing. And so the shifting recommendation opened the door to the public acceptance of misinformation and disinformation, which was sort of viewed as equal to what was coming out from the public health authorities. This became a case that was very prevalent, and it adversely affected the critical interventions such as vaccinations, masking, and following any of the recommendations or the orders that were given. So future pandemics continue with this pandemic as well, and other public health crises that are likely to occur with climate change and a whole long list of other urgencies that have sort of taken some of a back burner to the pandemic. You know, we have a limited understanding of what's going on, and as the science improves, the public health recommendations are going to change. Again, interventions are going to change. So how can we, as a public health community, and you as leading the public health department, prepare the public for the likelihood that changing policies and interventions are to be expected as we learn more? And that it's not a sign that we don't know what we're talking about, and that I think it's critical for, you know, as a way to intervene so that the acceptance of competing misinformation isn't a continuing problem.
Yeah, I totally agree with you. And I worry about the same issues. I mean, they're very real for us. I mean, we're actually debating this morning, we're going to be changing the quarantine guidance, and people were like, oh my God, like people are going to be so upset. But the science has changed. And we can't really lie to everybody. You know, we can't have a quarantine policy that doesn't reflect some natural immunity. We can't have a quarantine policy that doesn't reflect that vaccinated people, particularly when they make up the majority of the population, are very likely to get infected if you have a highly infectious new variant circulating. So I think the places we failed are places we have failed historically, and the work to repair this is going to take some time. So I think the two areas are, people don't trust us. They didn't necessarily trust us going into this. And then when you are, as you said, you know, changing things, you're dealing with uncertainty, you're asking a lot of people to develop that relationship with you during a time of uncertainty and to try to start to trust you. So we have to walk in the door with people feeling more confident in who we are and what we're doing. And the only way to do that is to get back out into our communities and build those relationships up again. I mean, I was part of the movement in public health that basically said, we don't need to be in the community anymore. The healthcare system is in there. We're going to be policy people. We're going to work on changes. We're not going to really necessarily be people that, you know, deliver services, that get into communities in an intimate way. And I think it's hurt us. I'm not asking us, we can't replicate and we don't want to be the healthcare, medical care providers, but as public health providers, people should know who we are. Because when somebody believes a YouTube video that shows that when you get that vaccine, you're getting a microchip put in over Dr. Simon or Dr. Davis standing up and explaining exactly what's going on, we have a big problem on trust. So I think the first thing is trust. And I think the second thing is transparency. People need the same information we have in a way that they can understand it, so that they can also live with the uncertainty better. You know, we sit with troves of information that helps us sort of say, oh, conditions are changing. Oh, this is, you know, sort of a new time. Oh, we've got some new studies. Well, if that information isn't easily accessible and available, then again, people are left, you know, sort of subject to the great campaigns that are out there, politically motivated often on misinformation. So I would say, you know, we have to start with doing some deep work around sharing our information, making sure that information is more accessible. We've invested a lot of time throughout the pandemic on being accessible ourselves because of that. But we have to do a better job. And then I would say the third thing is, I'm going to give a big shout out to former President Obama,
who actually is out there saying what we need now is ways to counter misinformation. Like often I think in public health, we have said, you know, that's out there. We don't need to worry about it. And I think we made a mistake. We do need to worry about it. And we need to figure out how we're going to best counter it. We've spent a lot of time recently on peer-to-peer, creating peer-to-peer education models for precisely this. You don't trust me, but you trust your neighbor or your friend or your aunt. And let's get a cohort of what we call public health ambassadors trained. So we have a student ambassador program, a parent ambassador program, a community ambassador program, free training, opportunity to talk to us regularly, have access to everybody in our department so that we can share information and then have other people in the community that both have access to us, but also access to people in the community. So I think we have a lot of work to do. I think you're right to note this has been a huge, huge issue and a downfall.
David.
Excellent comments. And also thank you for everything that you've done for LA last 2 years. And your talk was really a masterclass, I think, in data presentation and data communication. And this goes to the sort of the misinformation. And, you know, if we think back to the last couple of years and think back to when the pandemic started and we had this data availability, this instant, we could go online and we could see from the Johns Hopkins data dashboard, you know, what is available, what's the changes in cases and hospitalizations by time and where that was. And you know, think back to how other pandemics or other diseases could have been impacted, HIV in the 80s, if we had had a dashboard or something like that, right? And, you know, all of this information, but at the same time, there was misinterpretation of that information, broad scale comments about, you know, case rates here and there, and really not getting down to the, what you know, disproportionation or the heterogeneity of these things. And, you know, from an epidemiologic point of view, it really comes down to interpretation of absolute risk, relative risk, and the uncertainty of that. You know, the modelers got involved, myself included. And, you know, how many of those early figures from the models did we see where the peak went up and then it came down and gave the people interpretations of, well, let's just get through this surge and it's over, right? Instead of showing what we should have done is the uncertainty of where it would head eventually. And so, you know, I guess my question is what can we as academics and data interpreters, how can we improve for the future to help with the miscommunication and the misinterpretation in the data in the public health realm?
Yeah, I mean, at first I want to just thank everyone. I mean, you guys have done a masterful job, like actually doing some of the predicting and the modeling and helping us actually explain the uncertainty. So I don't think I'd be so harsh on sort of the uncertainty that's inherent in the modeling. I think it was pretty clear. And I also think it's been really helpful. I mean, I did call, you know, sort of as a short-term action goal for us that I think we need to create a better partnership though. Because I don't think there's easy answers to these questions. Like, I mean, I'm not really sure how we do a better job communicating on uncertainty. I mean, I will tell you that, you know, we're disadvantaged because the data is complicated. The story we're trying to tell is complicated. If I stand up and I acknowledge that vaccines don't work so great at preventing infections while I'm trying to get more people to get vaccinated, you could see why people are saying, well, don't share that information. Don't tell people. And I feel like, well, that is the worst strategy ever because everybody knows the vaccines aren't working so great. So if they don't hear it from us that they're not working so great, that doesn't really help. But not working so great and not working at all are very, very different. So what I think we failed at is being really good at sort of presenting complicated data in ways that people can understand it and hang with us long enough to actually have a conversation about it. But I don't have an easy answer. I mean, I do know that I think we would benefit from a more routinized partnership with the academic world, particularly those academic folks that are working on modeling or doing research studies. Right now, you know, thanks to Paul and Rashmi and their teams, you know, we comb the data, we comb, you know, the pre-published data to try to really better understand what the research community is looking at and what they're finding. But if we, in a city as rich as, a county as rich as LA in terms of academic partners, lost opportunity not to have created or start creating a more systematic way for us to collaborate. I know there's a lot that makes it hard to collaborate, people trying to get their research out, et cetera. But I think in the middle of a pandemic, we could figure out a way to do a better job than what we've just been doing.
We'll second that. Michele.
So first of all, I just need to say it is such an honor to be on the same stage with you. Barbara, you are my hero, and I am so glad that you have been our leader through these extremely difficult 2 years. So thank you.
Super kind, but there is a whole team of people here.
There's no question that COVID is a team sport, but we all need a captain. And so thank you for being our captain and leader. So I was told I could have one question. I have about 2 days worth of questions for you, but I'll try and get to one. And so as I think about this, I've really been asking the questions, just picking up on, I think, a discussion here, what are those lessons learned? There are, it's been obviously a very difficult couple of years, but we've seen some really phenomenal successes that have come out of the last couple of years. As Dr. Hood mentioned earlier, I had the good fortune of being a part of leading a Vaccinate LA, where we brought 14 schools and programmatic units within USC together and all harmonized our efforts to get out there and support our communities and to think about how to support vaccinations. And we engaged local artists. It was a community-driven initiative. We wanted to listen and learn from the community and then partner with them to really think about what are the right messages, who are the right messengers, and how do we deliver those? And I've always been struck by the message from one woman in South LA. She said, I don't want to hear from actors. I don't want to hear from sports athletes. I don't even want to talk to my neighbor who maybe's been convinced into this. I want to hear from God or my doctor that this is the thing to do, right? And so it is thinking about, as we've been working on the East and South LA, what are those targeted messages and who are the right messengers? But through that work, we've achieved so much. And I've learned so much as someone who's been doing public health for decades. There are lessons that I will carry forward in my work. But I guess, so my question to you, Kevin, it's sort of a twofolder. What do you think are some of the most salient lessons learned? And how do we carry those lessons forward as we think about not just COVID, but we have so many public health threats that are before us? And how do we take those lessons, again, if we're thinking about HIV or we're thinking about diabetes or we're thinking about any number of really critical health challenges in LA County?
Yeah, I think it's a great question. And first, I want to thank you and your team for doing all that work around vaccinations. I mean, that's the only way we've actually gotten to where we are, which is, we have about 75% of folks 5 and older in LA County fully vaxxed, is because there's been this tremendous collaboration. So I think that's my answer, is like the biggest success, I think, have been these expansive partnerships. And the lesson I think we should learn is that we should be investing in our community partners, faith-based community organizations, the non-chain, independent pharmacies, the small clinics, the solo providers, with real resources that are sustainable over time. Because the pandemic is a health tragedy that we're all living through, but there's lots of other areas where our outcomes for a well-resourced country look pretty dismal, particularly again in some of our population, among some of our populations. And the solutions to them are going to require strong partnerships. Those partnerships may be with organizations that help do organizing, that can help move forward on policy work. But nothing is going to be possible if we don't acknowledge the need to get resources to those organizations. So I would say the lesson we're learning is we got to have deep investments in these organizations that are doing a lot of amazing work in our communities, because social determinants of health has told us for decades now that if we want to see improvements and we want to close gaps, we got to address some of these root cause issues. And it is these community organizations, these leaders that actually hold the greatest promise to doing the closing the gap work. So my sense is, we got to figure out ways to give out more money, I mean, it's money and resources. I don't want to lie about that. Like, it is money and resources. It's not the only thing that I think is needed, but I think we should acknowledge how important these partnerships are.
Thank you, Michelle and Barbara. I'm now going to turn to the chat where a number of questions and comments have come in. I'm going to pose two of them at the same time. One was a question about essentially what does the county feel about vaccination rates and policies with regards to preschool children, infants, because of their tendency to act as a natural reservoir for reinfection for the rest of the community. And the second question is about how would the health department work to perhaps improve the ventilation and filtration in indoor settings, whether workplaces or elsewhere, since we now know so much about how important they are for reducing infectivity.
Yeah, thank you for those. Those are both great questions. We don't have a vaccine yet that's been approved for our youngest children, but let's just assume we will have one soon. I mean, the hope is within the next couple of months. And then the question is, should you move quickly to mandate those vaccines? I think that's the question. So this is where I would start. I don't think it's ever a great idea to move first towards a mandate when you get a new vaccine product. You didn't hear anybody on our public health department actually move immediately towards mandates, even for special populations at the very beginning. We think you have to start with education and understanding their concerns and answering their questions. This is also likely to get approved under an EAU, which again, I think there's legitimate concerns that get raised until it gets its final approval. So my sense is that we've got some work to do in order to be able to answer people's questions about safety and efficacy with the youngest population. If you look at a vaccination rates for 5 to 11-year-olds, they're dismal. Months out, we're well over 6 months. I think we've got maybe 30%, 32% fully vaxxed in that age group. Much lower than for any other age group, and reflects a lot of parent hesitancy because the parents are vaccinated, their older kids are vaccinated, and they're not vaccinating their younger ones. So I'd say, before we rush immediately to do the mandate, we should have final approval from the FDA so that everybody can feel very comfortable that the drugs have completed their entire regulatory process. And we should spend those months doing a lot around education. I do believe that at some point it might be absolutely essential to require vaccinations. I mean, I certainly am in favor of vaccine mandates at schools. Again, once there's final approval for the vaccine products, because again, similar to our youngest children, children do tend to be a reservoir. They are close together. They are in a place where it's really hard to prevent fully the transmission of a virus. And there can be pretty bad outcomes among children, but especially among the adults they live with, with a highly infectious, highly dangerous virus. So I think that's what we've got, highly infectious, highly dangerous virus still. And so I think there's a place. I also want to acknowledge that as we get more therapeutics, we should reassess what we need to do about vaccine mandates. Because right now we don't have therapeutics for everybody who gets infected. So there can be no reassessment because they're in very short supply. But if at some point you did have really good therapeutics and it changed the course of the pandemic, it made it less deadly, then you probably need to consider what you want to do with vaccine mandates. I know that's not a great, it's not like a cut and dry answer, but I think we have to do a lot of education. We have to get final approval. And then we have to sort of take a look whenever that happens at where we are with other tools that can turn this into a less deadly virus. Right now, it's super deadly from my perspective. Causes more deaths by far than flus, leading cause of death here in LA County. So for now, I think it's very deadly. And in terms of the second question, no, I think the question on ventilation, I think that's where like nobody's gone. Because it's super expensive to improve ventilation across the board. So I think this is, again, a worker rights issue. And this is why I was saying, we have to strengthen the rules that protect our workers. I think workers need to work in facilities that are well ventilated. And we've established, sort of these recommendations on what the air exchanges need to look like. So it's not like we don't have the data right now that says, here's how to make indoor air cleaner. Here's how to do better job on filtration. It's not like we don't have some products, both in terms of filters and improving the HVAC system. We just haven't had the political will to turn this recommendation into a requirement anywhere. And I think it will take embedding this in sort of an OSHA type regulation for us to actually be able to make a big difference. I do want to say we're all 2 years later, you can look on all of the public health websites and see much better information on ventilation now that we've acknowledged it's airborne. First year you could find nothing on ventilation. So I think there have been improvements there. There's been improvements on identifying good standards, but they all at this point are staying as recommendations. And again, I think this is an opportunity to improve the work environment for everyone. And it's not going to just help us with COVID. It will help with other respiratory illnesses and conditions that affect our workers.
Thank you, Barbara. We have a question from the audience here. Before I call on him, though, I just wanted to take note that we have a skateboard there, which means that we even have the cool crowd attending our session today. So it's very encouraging. Please, sir.
And that's
Can you identify yourself too?
Michael Dubé from Infectious Diseases, and that's I also have a bicycle helmet over there. That's mine. I'd like to thank you for you and your department's work on the Test and Treat initiative. Look forward to hearing how well that's working and what populations it's been able to reach. I don't think that we have the final word in therapeutics yet. There's still issues with drug interactions, tolerance, efficacy, and so forth with those drugs. Is there a way for the public health department to help promote clinical trials and participation in clinical trials to develop better therapeutics?
Yeah, I don't know. I mean, I'd ask Dr. Simon, who's our chief science officer, to talk more about sort of the clinical trials. As a public health department, we've seen our work less about promoting a particular clinical trial and more about promoting practices that allow very diverse populations to participate in those clinical trials. But I don't know, Paul, if you want to.
Hi, I come to you as a community member, so I'm from Southeast LA, and it's been a very bittersweet experience with the pandemic because that has offered a job opportunity to my family. My brother was a COVID screener. Sorry, he was an EMT. He went to a COVID screener. And likewise, as a research coordinator here at USC, I work closely with.
Good catch.
Thank you. I work closely with promotoras. So I have personally seen the importance of having these positions that employ community members to increase medical resources to our community. But unfortunately, these positions are short-term contract positions. So unfortunately, they're going to be left jobless in a couple of months. So in terms of the closing the gap actions that I've seen, having that pipeline to transition those people, promotoras, COVID screeners, into professionals in the healthcare industry would be immense because they can be able to apply their experience and skills into another position that is equally high paid. that can also help them if like they want to pursue like the medical career further in their life. So I want to ask if those programs will be prioritized, considering that these positions will be ending very, very soon.
Yeah, I mean, I think, you raise exactly the big issues. Like we find something, it works, we fund it with short money. We don't create it as a job category that has, opportunities for advancement. We don't look at, how we can expand training. And then you're right, we expect people who have short-term employment to do amazing jobs. So I share the concern and I share the hope and desire. I do know that the board has asked us as a county, especially the 3 health departments, to take a look at how we could support, more steady employment and all of, sort of the job classification issues that come with that at the county, so that in fact, these are secure jobs. I think in part, I think it's a faster route to actually fund organizations over longer periods of time to actually be able to offer well-paying jobs to promotoras, and then to have our role to help supplement on training. And again, I think it's faster if we get dollars out to community organizations. I also think they do a better job, frankly, on bringing in people and supporting people than, I mean, the county bureaucracy is big and it has a lot of advantages, but sometimes it takes a long time to create a new classification. And I don't think we have time to waste. So I think the effort right now should be on getting secure funding to the CBOs that are actually hiring, so that they can offer full-time employment to folks, or folks on part-time employment, but just secure employment. So, but I agree with everything you said, and I appreciate your speaking out on this.
Thank you.
Okay, let's take another question here, and then I'll see if I can also take one from the chat.
Thank you, and I really appreciate the option that you are offering about opening like a coalition or something like that. I think it's important that in that type of coalition, we get those promotoras de salud and frontline workers also as part of the members. But my question is related to how did the county handle the COVID-19 pandemic with the big homeless population that we have. I don't think we heard too much about it in the news. So I was wondering if you had any insights of, in my view, I was expecting to see more tragic deaths of the homeless population, and it seemed that it was not as much. So if that is a success story from the county, I think it would be important to be mentioned.
Yeah, thank you so much. It's super important. I mean, I think we don't hear a lot because, folks have been focused on other issues regarding people experiencing homelessness. I don't necessarily think it's a good story. I mean, I think there's been a lot of efforts and it's made a big difference. But I think we're about to actually publish a report that shows that there's increased mortality over the pandemic amongst people experiencing homelessness. Not necessarily, the leading cause of that isn't necessarily been COVID illness, but I think the impact of the pandemic on people whose lives are already fragile, who already have poor access to health affirming resources and healthcare has been tremendous. I will say that there has been enormous work that has been done to provide services and support to people experiencing homelessness during the pandemic. Teams, I mean, really, I think there's 150 people that are part of sort of these crisis response teams that have been working in all of with unhoused and housed people experiencing homelessness to make sure that they're well connected to testing and to vaccinations and boosters. And, that means going into encampments and lots of folks have been doing that. So I think we have about 65% of sort of, and this, there's no real denominator, so I want to be careful with this number, but about 65% of people experiencing homelessness have had at least one vaccine. And that's a pretty, that's not great. We're at 75% for the county, but it's decent. And it means that there's been a lot of effort. We've also had a lot of cases though. We have great partners with our shelters. So there's been a lot of work that's been done so that people can stay housed, but we try to house them in as much safety as possible. So that we've got places where people can go for quarantine and isolation who are either in shelters or unhoused so that they don't risk transmitting to others and that they get services for themselves. So these isolation and quarantine facilities actually have a lot of wraparound services. And then, as you know, we've used Project Room Key to try to prevent people who are very fragile from living in a situation that would create more danger for them because of COVID. So there's been a prioritization of trying to get folks who are most vulnerable for severe illness for COVID, who are experiencing homelessness, into Project Room Key sites. So I do want to give the county a lot of credit and all of the workers, and we've got a lot of private organizations as well helping that have done everything they can. But I still think the root of the problem of homelessness has during the pandemic led to an increase in mortality amongst people experiencing homelessness. And tragically, not necessarily all because we've had many more people who have been infected with COVID and died, but also because of the collateral damage that has been felt, I think, acutely by people experiencing homelessness.
Okay, I'm going to take one more question before we formally close, but you may have another opportunity to ask questions afterwards. We do have some time reserved for the press, but Carolyn, you'll have to tell me whether we still need it. So let's have a last question from Amy.
Hello, thank you so much for your talk and your time. It's been really great to hear from you leading and your team leading our this county, one of the most populous county through this pandemic. So my name is Amy. I direct the Master Public Health Program here. And I think one of the key message that you share really resonated with me is the importance of establishing partnership between public health and academia. And also, I think it's really important to establish a sustainable partnership between public health and the education program. And so as an educator of the next generation of a public health workforce, and we're constantly thinking about, are we training our students with the right tools and skill sets they need to go into this post-era of pandemic? And I see a lot of our students here, so it's really great to see our public health students attending, including the owner of this cool skateboard. And so, my question is, and for our students as well, what are some new areas and new skill sets that our next generation, our students really need to focus on top of and beyond the traditional principles of public health that we focus on?
It's such a great question. And, I really appreciate it. I mean, I'll just say like big gaps right now are people who actually have a lot of training in communications, but also are epidemiologists. Like the translation of information out to the public and the ability to answer questions that the public has and be data-driven about that is really at this point difficult to accomplish because we don't have a lot of folks who are trained. And no, our team really has felt this acutely. We have a communications team, which are people who have a lot of communication skills, in that office. And then we have our EPIs and our analysts who have tremendous skill about looking at data and trying to make sense of it. But you actually have to do both. And we don't have people who have both skills. So we're constantly trying to find somebody who can really look at the data, understand the data, but then communicate information with lots of other people about it. So I would say that's one thing that really, really stands out. I think sort of the world of analytics has really changed as well. So, just, I mean, and I know Dr. Simon can talk more about this because we're actually, for all of you who might be finishing up soon, trying to hire more people to help sort of really allow us to do more work on the analytical side that takes advantage of some of the technology that's out there, the mapping tools that are out there, but also allows us to do predictive modeling. So you guys are really good at predictive modeling. We need help, and we need folks who are embedded with us, who could help with some of that work as well. I mean, I think, the world of data has changed so dramatically. I mean, I'm pretty old, so certainly from my time, we didn't even have computers when I got started. So but I think, there's lots of information that's accessible, and there's lots of new ways to get really good information in real time. And we are going to constantly need people who are data architects, but understand public health to help us construct those systems. And then, of course, the world is at this point about being able to connect dots, build those partnerships, be able to understand how we can all work together and affect policy and practice. So I would say the third big area is people need to, see themselves as supporting community organizing, understanding how communities come together, how we can support communities coming together, how important it is to figure out how to make best use of the leadership that's there. So I would say, that ability to not see yourself as somebody with a lot of information to impart on others, but to see yourself as an authentic partner requires really doing some deep work around understanding racism, understanding root causes of health inequities, doing your own journey about how you're showing up in spaces so that you can actually be really a good partner with efforts to address the disproportionality that, really makes it impossible for us to be successful as a country.
Thank you. Thank you so much.
I'd like to thank Dr. Ferrer, panelists, Dean Meltzer, for giving us a wonderful event today. I mean, one of the things that was brought up is how not only does academia need to work even more closely with our public health department, but we as a brain trust together can also think about other simultaneous public health crises that are coming, whether it's climate change, antimicrobial resistance, et cetera. And being able to do that together, I think is part of what our aspiration is as a School of Public Health, which we will be within the next 12 months. Thank you again, and please follow us on our Grand Round series. We'll be back here. I'm sure we'll have Barbara back at some point as the pandemic evolves. But we'd love to get your input and insights as how this series evolves. And let's thank our speaker and panelists once more time.